Okay, guys, sorry about yesterday. We're going to be doing a simulation in well, kind of a two different types of way. Number one, we're going to be doing, well, three. Number one, it's going to be on mental health. Number two, we're going to be doing it online. And number three, we're doing it through Zoom, but not with you guys actually here with me. I do want to let you know and you probably read it as you signed in. I am going to be asking you questions about the scenario on the next one that we do, just to, and not that I don't trust that you're not going to take it serious, but I mean, this is something that is required and it's something that's very important. And I did work really hard on this case. So I do hope you enjoy it and really get something from it. A couple things I want to say before we start is that I did start sharing my screen actually now with you. I did try to pair this as closely as I could purposefully with the at home one that you guys did, if you can recall, which I'm sure most of you can. I know it was pretty comprehensive, but I tried to pair it together again so that things kind of meet up and make sense and the whole picture comes together. When I think of this scenario, which I was a big part of writing actually for San Jose State, I do have permission to use this because I did write most of it. And so all of that is kosher, if you will. And I wanted to mention a couple things. So one really cool thing is I actually have the scenario. So I will be showing you part of the scenario that they did. It's unfortunate because it's not the best quality. So even though you're not going to be able to really hear, and we're not going to watch the whole thing because it's way too long, and you'll notice why. And I'll tell you what I'm hoping for you to point out during, please, and really like assess, so that you can answer your board work questions, at hopefully a high critical thinking level. And we'll go over, of course, right down here, the brief summary of the case. I'm just going to shut out my face because I'm tired. So what we'll do is, the expectations for this simulation is, of course, is that you really think about what you're doing, please. I know we all have a lot on our plate. Finals are coming up. This simulation, I believe, is very, like I said, very well matched with what you had to do for your clinical at home. It's only going to help you be able to think more critically. And my main goal from writing the sim, again, going from the VN role being a little bit more task-based, not that LVNs cannot think critically or in a big picture, because they absolutely can. However, the RN role, that's really, what we're trying to instill within each and every one of you. So I would like to really look at this piece, and I will mention it throughout, is how everyone's working as a team. So you'll notice, number one, in the simulation that we're going to be watching, so this is three parts. One, I will read about the patient. Two, I will explain what's happening to the patient in the moment. As we're going through that, I would normally ask questions. I will explain certain things just in case, or little side notes. And then we'll watch the little piece of the video. And again, even if you can't hear it, I just want you to assess the patient. So our patient today is going to be a schizophrenic, or sorry, I don't like to say that, somebody who has schizophrenia, as well as his dual diagnosis. He also suffers with alcoholism, and he did have THC in his bloodstream when they found him in his system. So with that said, we're going to do the reading part first with a little bit of explanation, a little bit of lecture. We're kind of doing it backwards, because we are doing it this way, but we're getting it done. And I think you'll enjoy it. Then we'll watch the video for probably just about 6 minutes, even though it's 22 minutes long, and I'll explain what does eventually end up happening. But I think it's a really good indication of being able to see, if you didn't get to see this in our clinical, because we don't get to see everything. This is very, and I mean, people that work in mental health that did this already had said, oh yeah, this is definitely, it seems dramatized, but it's really, if you have not seen it before, it can really get to this level. And it's very sad and very difficult for us on the other end as well. So, okay, let's just start off and I'll talk you through it. So today, we have a patient, and then at the end, of course, I'll tell you where to find everything and how to turn it in. All right. And this will not be due until Sunday at 11:59 because obviously, I mean, it's not fair to say, turn it in 3 hours or today, I know you had med surg. So we're going to start just with a summary of the actual case of this gentleman. So this is a patient who is homeless. He is an adult male and does refer to himself as male, brought in by an ambulance after being found unresponsive, lying in the street, smelling of alcohol. Blood draw results in the emergency department were alcohol level of 0.26 and a drug screen positive for THC. He has a history of schizophrenia with paranoia, and per last hospital record, the patient was prescribed Zyprexa 10 milligrams. Patient is admitted to a medical surgical unit for IV fluids, monitoring, and stabilization. Patient becomes uncooperative and agitated on morning of hospitalization of day 2, requesting to leave against medical advice. The learner is expected, so this is what I'm hoping that you get from it, of course, is to watch the nurses while they're in there, how they're doing with therapeutic communication. I do want to mention these are, at the time, were fifth semester San Jose State nursing students who had never had mental health. Now they're changing it so it's second semester, more like how we do it in our programs, do it in the beginning for our VNs and as well for our LVNs going into being an RN, because learning how to communicate and being therapeutic, and I mean, some of it comes natural, sometimes it doesn't. It's just being exposed to those kind of uncomfortable situations can be very important in the beginning, because it's going to be, as I've said many times, you're going to see it all across your career, no matter where you work. So, but they did, I mean, God, I was astonished, actually. That was my first semester working at San Jose State, and actually my first simulation, I was kind of thrown into it. They said, oh, can you write one, and we'll be there tomorrow. So they did a very good job. So please watch for the therapeutic communication, how they're dealing with the patient. We've already talked about CWA. Again, I tried to connect this to your at home. So the CWA and the scale, and please also, just their behaviors, how they're dealing with the patient, how they're speaking with the patient, and the holistic part of it. So they actually have a social worker come in. The patient is very med non-compliant, doesn't want medications, is at risk for seizure. There's all this stuff going on. It's a huge onion of layers, basically. And the hope is that we're able to meet the patient's needs, get them to be safe, have you be able to do an SBAR of what you would do if you were to call the physician, MP, PA, whomever that may be. And of course, safety is for every patient and yourself, maybe even more so in this case, because you can tell the patient's increasingly getting agitated. And of course, we want to prevent any seizure activity from withdrawal from the patient having alcoholism or alcohol use disorder is what we call it. So now I'm just going to go through a few things. If we were in person, I would ask a couple things. Number one, I would ask, so the patient came in smelling of alcohol. So even if they didn't smell of alcohol immediately, what I would want to do as an assessment is know what's going on. Obviously, they're found unresponsive. I would want to get a tox screen ASAP. That's usually pretty standard in the ED. So I know what's in their system. So I know what, if I give them this, what's going to interact with that, or could this person go into a seizure right now? It really helps give us that big picture. But then on the contrary, on the other side, if they are smelling of alcohol, that's an assessment, right? So we get our assessment, then we're going to do an intervention and then do more assessment after whatever the protocol is or whatnot. The blood draw was done. Alcohol level, for those of you who don't know, I compare it to Amy Winehouse. So on her death certificate, she had a 0.40. That's considered a lethal level. However, I do want to say, as a side note, so 0.26, I mean, he had, that's quite a bit of alcohol in your system. It again depends on all sorts of things, tolerance, the person, and I want to make it very clear, it does not matter how big you are always, okay? So you can have somebody who's 6'5", 200 and whatever, 50 pounds, who gets way more intoxicated than someone who's 5'1", 100 pounds. That really is true. That can happen due to tolerance, due to genetics. Our body usually will metabolize about an ounce an hour. So, but again, everyone's different. What if your liver's not working as well? We don't know this guy. Maybe his liver is fibrotic. So he's not going to be metabolizing alcohol the same way somebody whose liver is considered, I'm doing air quotes, more normal or in better condition. So there's all of these things that it's in the back of our head, but what's most important and knowing the priority, that's kind of the key. And what I don't think I actually finally said, and I mentioned the social worker, is the fact of working together, not just treat them and street them kind of thing, right? What's going to actually help this patient from having that revolving door? Hopefully, of course, it's still going to happen with patients, but what are we going to do? Let's try to find housing. Let's try to do everything we possibly can. The system is not perfect. It's not made perfect, but doing the best we can is hopefully, that's why we're here. And that's why we went into the profession that we went into. So, and just, I wanted to mention, I've had a patient, I always loved hearing true stories from you guys as well. I had a patient have a point, what did she blow? Or it was a breathalyzer, so it's different, but basically it was like 0.5. That's dead. I mean, she was smoking a cigarette. I'm laughing, it's not funny. Outside of the emergency room, while we're waiting for her to be seen, because we have to get people cleared before they come into rehab, right? And it's just, and she's sitting there having a pretty coherent conversation. She was so tolerant of alcohol. Her body was able, I have no idea, it's the highest I've ever seen. It was 0.52, if I remember correctly. But I've seen 0.46. I've been urinated on, because people tend to lose their capacities and will, defecate or void or vomit, all sorts of things. The next thing we have is, we know now from the history, because we have some hospital history, which is very helpful if we have something to go off of, because we may not know he's schizophrenic. And then if he wakes up, oh my God, it could be very dangerous. We don't know if this person overdosed on opiates and we need to give them Narcan. There's so many things that we have to be thinking about at once. And then we see that the patient is on Zyprexa. So just a little hint, and this will not always work, but if you don't know what Zyprexa is, let's just pretend, and you're taking your NCLEX and you looked at that medication, and then again, this will not always work, but hey, I'd rather have, if you have no idea, let's take the best way possible of getting it right. Well, just said they're schizophrenic or have schizophrenia and addiction. We went over the addiction meds pretty well. Okay, I don't say antabuse, no, methadone, no. Oh, okay. So more than likely, what is Zyprexa? Even if I didn't know, probably an antipsychotic, because we know the patients that are schizophrenic, that have schizophrenia, even though they might not take it, are always on an antipsychotic, or hopefully should be, to help those positive symptoms of schizophrenia. So Zyprexa is this, which I know you know that because that's on your list for your final. It is an antipsychotic, which helps lower the level of dopamine in the brain. And then the last thing I was going to ask, if you were here with me, would have been having to do with, why do we think that this patient all of a sudden became uncooperative on day 2? Why not day, like first couple hours, or like, let's say within, I'm just going to take a drink of water, one sec. Thank you. Or like, let's say day, hour 24. And I wrote this, so I know why I did it like this, but more than likely, if we had to guess, it's because he woke up and now because when he first came in, they probably knocked him totally out with benzos, because what do we usually give? Not always, sometimes yes, phenobarbital, but more than likely, they probably gave him Librium or Valium or Ativan. In this case, they are using Ativan. And as we know, Ativan is a shorter, and now that would be something else I'd ask, and I know you'd all get it right because that's on your final too. What has a longer half-life, Ativan or Valium? We know that Ativan has a shorter half-life. And so we know that he's been probably knocked out and now is probably conscious. More than likely, they probably pumped him full of meds. He was knocked out, and that's why. So again, looking at that bigger picture, why this, why that, kind of getting a general understanding of not just, okay, these are the facts. Okay, let's do this, that, the other. Okay. And then also thinking about the patient. This is a human being. This person, and I mentioned this before, some people like to be homeless. They want to be homeless, and that's okay. If this person wants to be homeless, they can be homeless. However, there are places that this person can go, and we'll learn a little bit more about that. Okay, so now I'm going to tell you in this current moment what's happening with the patient so that it makes sense. And I'll show you the video again. It's very hard to hear, but it's more about watching the patient. And then you can kind of hear at certain points. But I really want you, I'm almost kind of glad you can't hear, because I want you to assess the patient, their actions, their movements, and all of that. Excuse me. Okay, so in this moment, we have a 33-year-old male with a history of alcoholism and schizophrenia, and he is admitted to the medical surgical unit floor from the emergency room last night after being found unresponsive in the street. He is presented to the ED, and he is only responsive to painful stimuli, meaning that if you just kind of shook him, I can't say that word, sorry. My vocabulary is not the best. So painful stimuli, when they take the needle and like poke your foot or something, with positive drug and alcohol screening, along with low magnesium level. CT of head was within normal limits. We're always going to do a CT. CT equals potential bleeding, right? That's how I always think it. So if we think there's potential bleeding, get that person in a CT. He was found on the street and responsive. I'm going to get a CT. Did he have a stroke? Is he having a brain bleed? What's going on? And if you have alcoholism, you're not going to clot as well. So you could be bleeding out right now, right? Because we know that we have albumin, which our liver makes. And if our liver's not functioning as well as it should be because we have alcoholism, our body's not creating as much albumin. And if we don't have as much albumin, which is a large protein, that's not helping. Oops, that's something different. Oops, pretend I didn't say that. I was talking about ascites. My apologies. I get excited, when I talk about addiction. The platelet counts. So your liver is responsible for platelet counts and creating that part, the PT, PTT, and all of that. So we definitely want to make sure. So we've ruled that out. That's excellent. IV fluids, of course, are given due to dehydration. Alcohol causes dehydration, and plus potentially, and we can't always just assume that they're dehydrated because they're homeless, but potentially, okay, let's pump them with fluid. It's not going to hurt unless congestive heart. We know why it would hurt. Was administered and patient is being monitored monitored since admission. He is a poor historian about his past medical history and drug and alcohol use. Then in this moment, the patient is now, day 2, is alert, oriented to name and place, becoming increasingly agitated. So please watch for that. And why? Like watch what is he doing that's showing you this? Even if you can't hear him. With notable tremors, that's not good, right? Tremors shows CNS agitation. That can equal more potential for having a seizure. Not always. You don't always have to have tremors to indicate that a seizure is going to happen, but that is indicative that your central nervous system is not doing well. So we have to be really careful with that. Also, please watch that the patient is pacing, is talking to themselves, and is uncooperative with care, as well as the patient asks every person who enters the room to sign his notebook and continually asks about the location of his or his belongings and his dog. So the patient becomes restless and frustrated, expressing a desire to leave the hospital. Very, very common. Anyone that's been to mental health has probably seen this part. And I'm understanding anyway, but imagine being stuck in a place that and if I were the physician, what I would do, honestly, I'd put him on a 5150 if he tried to leave, so he can't go. And then I'd 5250 him until he's stable. Because he's at risk to himself to have a seizure. He's having tremors right there. Boom, done. That's what I would personally do. Then there's no question about it, basically. So imagine being in a place you have no control, and I'm saying in your normal, again, air quotes, normal cognitive state, being in a place where you have no control, you don't have your animal who you love, You don't have really like a say of what's going on. You're scared. Okay, let's just make it short. There that is. That sucks, and that's scary. Now put on top of it, you are in withdrawal, so you feel like crap. You don't feel good. Plus, you're paranoid and you have schizophrenia. I mean, just pile all that on top of it. And I mean, really, this person is in danger to themselves and others at this point and is gravely disabled. That's everything. So that would be my plan of care personally. 5150, 5250, get them stable, find them good housing, this and that. You'll notice in the video what they're trying to do. The social worker does such a good job, and she's actually a nurse. She's amazing. They all are. They're so. I mean, all of you guys are too. But I was just very for their very first sim for mental health. I was like, holy wow! It was pretty impressive. I guess is all I'm trying to say. Okay, so now we know where we are, and let's go ahead and stop sharing the screen, and we will share here. So. Again, you're not going to be able to hear as well as normal, but just observe, please. And this part of it is almost done, in case you're wondering. Okay, so here we are. They use real humans as their patients for most of their simulations. So this is the patient over here, and then the nurses knocking.
Hello, Mr. Kelly. My name is Daniel. I'm a nurse, and this is Sarah. She's also a nurse.
Hi. Can I please ask first, before we do anything, that you please sign my book?
Sign your book?
Yes, please.
And what is your book for?
It's just my book of names.
Okay.
So I can know what's going on and who I was with.
Okay. Yeah, let's go ahead and do that.
Okay.
I'll let Sarah sign first, and then while she's signing it, can I ask your name and date of birth?
Can I ask where my belongings are, please?
Where your belongings are. Do you want to go ahead and take a seat?
No, thank you.
Okay. I'm not exactly sure where your belongings are. I see that there's a bag right next to your bed. Would this possibly be your belongings?
Where's my dog?
Where's your dog? You want me to sign this, please?
So, Mr. Kelly, we have to do an assessment of you today. Do you know why you're here?
I was brought here against my will. I'm supposed to be taking care of my dog. I don't have my things, and I need to get out of here right away.
Okay, we'd like to get you home as soon as we can, and so you can take care of your dog. So you were here because you were found unresponsive in the street with a high amount of alcohol in your system. So we're here to treat that today.
Can I please just go now? And I need my things, I need my dog, I need to leave.
First, we'd like to do some tests just to make sure you're okay. Are you having any tremors in your hands? I can see that. So maybe we can get you some medication for that, so it doesn't elevate to anything more serious.
I'm more interested in just getting my things
Getting your things and leaving.
and getting out of here.
But as nurses, we want to make sure that you're safe and well talked before you leave. Are you on any medications right now?
I don't know.
You don't know? You don't know if you took any medications today, this morning?
I don't know.
Okay.
But I do know that I need to go now.
Okay, we're gonna get you out of here as soon as we can. Did you take your ID out of your hand?
It just came out.
Okay. So before you go, we'll need to patch that up.
Okay.
Okay, can we do that for you?
I'd prefer if you did not touch me.
Okay.
Okay. I can say with Mr. Kelly that you want to call the charge nurse to make sure that we have everything.
Okay, yeah.
No, this is taking way too long. I'm just gonna call
Hi,
an
charge.
Uber.
Hi.
Well, she's
So,
taking charge of right now. We're getting things going.
What?
Okay.
Okay.
If if
We
you don't
gotta
mind, while
we
we
have to
wait
do
for
a
her
med
to
So,
get the
can you
charger, I'm
talk to
just
him
gonna
before we
ask you a
get
few questions. Are you having any
Okay.
nausea,
Mhm.
vomiting right now?
Daniel,
Are you feeling
I'm gonna have the
that?
social worker come in and talk to him.
Okay.
So we could do this.
Hi, Mr. Kelly.
He's very agitated.
My name is Mary. I'm the
So
social
I need to
worker.
give
Hi.
him
I'm doing good, but I need you to please sign this book for me before.
Okay.
So he's gonna
before
need
anything
the
else
lorazepam.
happens.
Okay,
And
I just
I'm
wanted to
gonna
let
give
you know
him
I'm doing
the,
great because your doctor.
do you think I
would
should
like
start with
consult,
that,
or
or should I
would it be
do
okay
both?
if we grab a
What's the
tea and I
other
can
one that
talk
you
to
need
you
to get?
the
about
Geodon?
your
Trazodone?
card before you head out?
I can't have a seat right now. I'm too anxious.
Okay.
I need my
Okay.
dog. That's
Okay.
all I can really think about.
I'm
And my
wondering-
friends, and I need my dog.
Where's
Yes.
your dog right now?
Okay.
And my friends watching him.
Okay, and do you have a place to go once you leave the hospital?
They said that they're-
Yes, I can, but I want to make sure that you have a place to go so that way we can let you out of the hospital. We don't want to let you just anywhere. We want to make sure you have a place to stay.
I can find a place to stay.
Okay, if you'd like, I can help you find a place for you and your dog to stay. I have a lot of resources.
Okay, sure.
Yeah, okay, would that be okay if we grab a seat and I can talk to you about it?
Actually, I'm just gonna call an Uber right now.
Okay, well, I can help you find a place to go and I can help you, get a taxi there if you'd like, and then we can, you can be with your dog after we get all the discharge papers done.
Should we
after
get it
the-
ready?
Give you your medication. If you help me out with that, yeah, you could be out of here in a couple hours. Would that be okay?
That doesn't sound unreasonable.
Okay. So do you have any family, any friends nearby?
No, just some friends.
Okay. And it's just you and your dog and you want to find a place to stay, correct?
Correct.
Okay, have you taken your medication?
So,
Yes, I will find your book, but have you been taking medications or?
could you please say your and just sign over?
Did you take any medications this morning? It'll just make it easier for me to find, for me to get all the paperwork done, so I can send you to. I should know when the last time you took the can't remember. Okay, do you guys have any record of him taking medication earlier today?
We can check the bar next time, sure.
Okay.
Yes,
Where's, do you know where my belongings are?
Okay, so as you can see, Mr. Kelly is quite agitated and he's struggling. He's really struggling. Whether you could hear him or not, there's parts that are pretty a little bit more vocalized than others. He's definitely struggling, not doing well, not in a good place where you would want to send him to leave, and I think that that's quite clear. Some things that I would like you to let me just go back to my screen here so I can share here. Some things I would like you just to kind of think about is that how the nurses interacted with the patient. So I'm just kind of showing you the chart as I'm talking. So how the nurses interacted. Again, imagine walking and you've never had a real encounter with a psychiatric patient to this acuity. Of course, it's going to be a little bit, kind of like, a little bit nerve wracking. But if you notice something very interesting, did you notice how when the third nurse came in, who was playing the social worker, mind you, just so you do know that the patient is a nurse, Noah, he's fabulous. And I got his permission to say his name. So Noah was the patient. And he's just was the perfect person to play this role. Very realistic. And again, that holistic piece of it. Once she met him where he was at, and again, I've said it 100 times, we can do everything perfect and things still won't work the way we were hoping. It's not easy to deal with just human beings in general. And in circumstance, we don't know, just like if we go to the grocery store and we say hi to somebody and they don't say anything back, or you open the door and they don't say anything back, we don't know what just happened. Maybe their family member just died and they're just in such a fog and they have no idea what's going on. They don't even think to say thank you, right? And I think we had a conversation similar to this. I don't know if it was our clinical or in class, but really recognizing that we'll do everything we can. And there was a very different, if you notice from the beginning, not that the two nurses did anything wrong. They did very well, but they were coming from a different position. They were coming from more of a task-based, I need to do my CWA, my little Daniel. Just, and I mean, God, he's probably what, 20, never dealt with anybody, not that age matters, just saying, never dealt with anybody with any psychiatric problems before or diagnoses. And he did a very good job. He remained calm. He was a little bit obviously nervous, but he remained calm. He was respectful. If you notice, they all kept their distance. They kept themselves safe. They, signed the book. What's the harm in signing the book? Obviously, if the patient said, put your address down, I mean, there's certain things we'd watch for. But to kind of summarize and sum things up before I post this and post your board work, I just really want to say that if you notice the beginning of the video, and their main goal is getting the medications, making sure the patient's safe, all correct. Daniel was trying to do the CWAL. That's why I asked about the, if you saw on the clip, he had a clipboard. He was trying to do the CWAL. The patient really, if you really think about it, sound and mind wise, isn't able to objectively, subjective, I always get those mixed up, subjectively be able to actually like answer the questions, because he's not considered to be in the right state of mind as far as being cognitively intact, right? So he's off his medications, he has these diagnoses, all this stuff is going on. Then the social worker walks in, and what does she do? And I remember being in the room watching through the window, and I was just like, wow, she's got a gift. She met him where he was at and said, we want to get you out of here as soon as possible as well. Can you help me do that? Can you help me do that? And did you notice his whole body language changed? And he became much more cooperative, and he said, that doesn't sound unreasonable. How it ended was, it was just trying to, push the meds. And they basically told the patient to not take the meds. And then at the end, when we did our debriefing, just so that you guys know, because we will be doing a debriefing next week on this case, because I do want to talk about it, is the fact that he, in the real world, like I said, and I told them that because I had another instructor in there, and she's an OB instructor, and she said, well, what would you do? Because she didn't know. And I really appreciated that. We're not all experts at everything, right? And myself included. I mean, I worked in psych. That doesn't mean I'm an expert. We learn something new every day from everybody. And I said, well, at the point of, resisting and not cooperating, not because he's trying to be difficult. I mean, obviously he's going through a hard time. I would put him on a 5150 for safety. He's not going to like it. More than likely, there's going to be a takedown. There's going to be Haldol or Risperidol, something, probably a B52, which is Ativan, Benadryl, and Haldol involved, sedate him, inject him with medication for Invega, probably. This is just something that I'm thinking of that I would probably do if I had a patient in this state, because I want him to be safe. I don't want him to have a seizure. Did you see those tremors? Those are not good tremors. So no tremors, good, but that was not good. And he was very, very adamant on leaving. What do you think is going to happen? I mean, he could have a seizure, hit his head, fall, and die. I had a patient maybe it's been 3 years now. Had her in my rehab twice. I don't take people more than twice. I think it's unethical, because let's try something different, not that we didn't do our job. And unfortunately, she relapsed and hit her head, broke her neck, and died. I mean, it happens. These things happen. And if I can help prevent that, I'm going to help prevent that. So I'm going to make these decisions that may look not good in the moment, because it doesn't look good when you're taking somebody down, if you will. And that's how I say it. I mean, because it is, you're taking somebody down, and it's not fun to watch. It's not fun to be a part of. It's not something, I mean, that's just not my cup. It's not something that I enjoy to do. But I mean, if you need to do it for the safety of that person and you know where you're coming from in your heart and you're not doing it for reasons of being selfish and just, oh, I don't want to deal with them, then we know. Okay, so I think I've said enough about the as far as what's going on with the patient. What I'm gonna do is I'm gonna so how you're gonna find this information is this way. I'm going to go ahead and of course post this just for your, you don't need it to answer the questions, but just for your knowledge, of course. So I'll post this. I'm gonna post this video as well, and I'm gonna post the board work. The only thing that you need to turn in via email to me is, and this goes for both Jan's groups that I would have had at 8 a.m. yesterday and 11:30, to my email by 11:59 on Monday. And then I'll figure out how to do a complete or not. It just ended up being messy last time because it made everybody have a grade because I told them turn it in under mental health and it was like a mess. Please go under Mrs. Dyer's journal and write something to the fact, so it doesn't show something is missing, like something to the fact of, you know, had some mental health with Miss Amanda or something like that, just so that it's clear that obviously you turn something in with me. She already knows. If you don't do that, it's not the end of the world, I don't think, but I just, you know, let's cross our T's and dot our I's, if you will. And I will get this uploaded and get the board work up. And I hope you guys learned something. I mean, it was, I think, a pretty interesting case. And I think it's kind of cool to watch somebody else do a simulation from a different school, kind of get a different feel. And we'll definitely revisit this for probably about maybe 20-30 minutes, starting with our next case. But we will meet via Zoom next Tuesday as well. And we're going to do an ATI real case, which is on anxiety, panic attack. Excellent. Or is that the one? Yeah, because we did borderline in class. So that is it. I will post everything for you guys. And thank you so much. I truly apologize about yesterday. And I look forward to seeing you guys very, very soon. And let me know if you need any help or you have any questions. Again, email me. The only thing you're turning in is the board work. I'm going to post the board work under announcements. I'm going to post everything under announcements. Everything's going to be there. It's going to be very crystal clear. Obviously, you're hearing this now, so you're already going to see it, but it will be clear. And thank you for your time.